Hello and welcome back to my YouTube channel. Now onwards, I will be starting the oncology series for you all. In today's lecture, I will be talking about testicular tumors. So first, I will be talking about the anatomy of testis, histology of testis, and then the morphology of testicular tumors. So let's get started. Anatomy of testis. Testis is a paired organ suspended in scrotum by spermatic cord. Each testis is attached to an epididymis which connects rete testis to vas deferens. Testis is composed of convoluted seminiferous tubules and stroma. There are three layers surrounding testis: the outer tunica vaginalis, tunica albuginea, and inner tunica vesiculosa. The seminiferous tubules converge into rete testis at hilum and stomose into efferent tubules that penetrate tunica albuginea to form head of epididymis. Histology of testis. Testis is composed of seminiferous tubules. These seminiferous tubules are 150 to 250 microns in diameter and are lined by multilayered epithelium with most mature cells towards the lumina. These seminiferous tubules contain Sertoli cells, spermatogonia types A and type B, primary spermatocytes, secondary spermatocytes, spermatids, and spermatozoa. The Sertoli cells are the cells which are columnar on basement membrane and they surround germ cell elements with cytoplasmic elements and form blood testis barrier. They provide nutrition to the germ cell elements. Leydig cells. These cells are cells which have abundant pink cytoplasm with lipid or lipochrome pigment, Ringke's crystalloids, which are hexagonal prism on electron microscopy. They have round nuclei with distinct nucleoli. These Leydig cells are seen in clusters between the seminiferous tubules, and these cells produce testosterone in response to luteinizing hormone. The WHO has classified testicular tumors in four broad categories: germ cell tumors derived from germ cell neoplasia in situ, germ cell tumors unrelated to germ cell neoplasia in situ, sex cord stromal tumors of the testis, and mixed and other sex cord stromal tumors. Talking about the pathogenesis of testicular neoplasms. Well, 95% of testicular neoplasms arise from the germ cells and almost all are malignant. The risk factors include positive family history, cryptorchidism or undescended testis, gonadal dysgenesis, androgen insensitivity syndrome, presence of isochromosome 12p. Most testicular tumors in postpubertal males arise from a precursor lesion, germ cell neoplasia in situ. So we can understand that broadly testicular tumors are of three types: germ cell tumors, sex cord stromal tumors, and mixed tumors. The testicular germ cell tumors are further categorized as seminomatous and non-seminomatous. In this lecture, I will be talking about seminoma, yolk sac tumor, embryonal carcinoma, choriocarcinoma, and teratoma in detail. Seminoma. Seminoma is the most common malignant germ cell tumor in adults. It presents as painless palpable mass. Grossly, the seminoma is a homogeneous solid cream or gray colored tumor with surface nodularity and lobulation. Necrosis or hemorrhage is usually very minimal in these. The microscopic appearance, well, seminoma is composed of lobules of neoplastic cells which are pale or clear due to presence of glycogen. The nuclei is polygonal and have prominent one or more nucleoli, and the fibrous septa separating the lobules have a lymphocytic infiltrate which is composed of T lymphocytes and plasma cells. The seminoma tumors are radiosensitive tumors and respond very well to radiotherapy. The positive tumor markers are OCT3-4, CD117 or c-KIT, placental alkaline phosphatase, and in 20% of cases, HCG is also showing positivity in these tumors. These tumors usually spread via lymphatic spread and they go to retroperitoneal lymph nodes initially and later mediastinal and cervical lymph nodes. A distinct type of seminoma is spermatocytic tumor or spermatocytic seminoma. whose origin and pathogenesis is distinct and very different from normal seminoma. These tumors rarely metastasize and have excellent prognosis, and they are generally encountered in elderly over 65 years. Yolk sac tumors are the most common tumors of childhood or infancy. These tumors can be prepubertal and postpubertal. When these tumors are postpubertal, they are generally almost always a part of mixed tumor, and when they are prepubertal, they are usually pure forms. In yolk sac tumor, alpha fetoprotein is elevated in 95 to 98% of the cases. These yolk sac tumors present as unilateral palpable mass. Grossly, the postpubertal type yolk sac tumor are poorly circumscribed, non-encapsulated, and predominantly solid. They are gray to white to yellow to tan and have gelatinous surface. Hemorrhage, necrosis, and cystic areas are common in these. In prepubertal type yolk sac tumors, they are more homogeneous, gray to yellow, solid or mucoid, and have bulging and lobulated surface. In these, hemorrhage and necrosis are uncommon. The microscopy of these tumors reveal remarkable heterogeneity with multiple patterns, which are often combined. For example, microcystic or reticular pattern is the most common pattern encountered in yolk sac tumor. In this, anastomosing cord of flattened cells forming a honeycomb or spider web meshwork, forming spaces enclosing mucoid or basophilic material is noted. Other patterns are macrocystic, myxomatous, spindle pattern, solid cells, glandular, papillary patterns, etc. Hyaline globules and Schiller-Duval bodies are encountered in these yolk sac tumors. The Schiller-Duval bodies are papillary structures which are around a vessel and are composed of multilayered sheets of columnar to cuboidal epithelial cells, tumor cells. A distinctive feature of yolk sac tumor is the presence of structures resembling primitive glomeruli, so-called Schiller-Duval bodies, and presence of hyaline globules, which contain alpha-1 antitrypsin and alpha-fetoprotein, which can be demonstrated by IHC techniques. Embryonal carcinomas are pluripotent and malignant germ cell tumors resembling undifferentiated stem cells during embryonic development. These tumors are pleomorphic and high grade. They usually occur in combination with other types of testicular germ cell tumors. They have generally elevated serum HCG, alpha fetoprotein, and LDH levels. They present as palpable painless mass, and their margins grossly are ill-defined with foci of hemorrhage and necrosis. On microscopy, the tumor cells are arranged in sheets, primitive glandular pattern or papillae, and have basophilic cytoplasm, are large with indistinct borders, large nuclei, and prominent nucleoli. Choriocarcinomas are the tumors that arise from trophoblastic tissue and consist of syncytiotrophoblasts, cytotrophoblasts, and intermediate trophoblasts with associated hemorrhage. They present with elevated serum beta HCG levels and scrotal mass with or without pain. They have an early hematogenous metastasis. Grossly, these tumors present with central hemorrhage and necrosis surrounded by viable tumor, and the tumor size has a wide range. On microscopy, the tumor consists of syncytiotrophoblasts, cytotrophoblasts, and intermediate trophoblasts with associated hemorrhage. Teratomas. Teratomas originate from germ cells with more than one embryonic germ layers. That means it can be derived from ectoderm, endoderm, and mesoderm. They may occur at any age. Pure teratomas are common in infants and child and are generally prepubertal type. Grossly, these tumors are lobulated with cysts of mucinous, gelatinous, or serous material. On microscopy, there is presence of cartilage, bone, neural tissue, stratified squamous epithelium, bronchial mucosa, glandular elements, skin adnexal structures, etc. So there can be a combination of multiple elements in these tumors. The teratomas are of mature and immature type. In mature teratomas, generally tissue structures resemble tissues in adults, and in immature teratoma, the tumor tissue generally resemble fetal or embryonic tissue. The prepubertal teratoma tumors have benign course, and postpubertal teratoma tumors have malignant course. Rarely, non-germ cell tumors may arise from teratomas. For example, squamous cell carcinoma, adenocarcinoma, or various sarcomas. And then it is known as teratoma with somatic type of malignancy. Seminoma and non-seminomatous tumors differ in their behavior and clinical course. Seminoma often remains confined to the testis for long periods and may reach considerable size before diagnosis. Metastases are most commonly encountered in the iliac and para-aortic lymph nodes, and hematogenesis metastasis occurs late in the course of the disease. The non-seminomatous germ cell neoplasm tend to metastasize earlier by lymphatic as well as hematogenous routes. Hematogenous metastases are more common in liver and lungs, and the histology of metastasis and distant recurrence may differ from that of the testicular lesion. Treatment of germ cell tumors. Well, for treatment, radical orchiectomy with radiation or chemotherapy is done. The prognosis depends on the stage and histological type. Seminomas have best prognosis as they are radiosensitive and chemosensitive and usually presents with low stage disease as they have an indolent course. Non-seminomatous germ cell tumors, 90% of them achieve remission with aggressive chemotherapy. Some points to remember. Pure embryonal cell carcinomas are more aggressive than mixed germ cell tumors, and choriocarcinoma or mixed tumors with high percentage of choriocarcinoma have poor prognosis. I have tried to incorporate all aspects of testicular tumors in this lecture. I hope you have understood this lecture well. I will be posting MCQs related to this topic in the short section of my YouTube channel. Please do attempt those questions and I will see if you are listening to all the points nicely or not. See you in the next lecture. Bye for now.